All right, welcome to Chapter 11, dealing with the spinal cord and the peripheral nerves. We're going to talk about the anatomy of the spinal cord, talk about the cranial and the spinal nerves and their function, describe a reflex arc, a dermatome, talk about the different nerve plexuses and the important nerves that come off of them. Okay? The spinal cord runs from the foramen magnum of the occipital bone to L2, just below the bottom rib. What protects the spinal cord are the cerebrospinal fluid secretions and the meninges, as well as the denticulate ligaments in the filum terminale, which anchor the spinal cord both vertically and horizontally. The denticulates anchor it horizontally, so it doesn't go side to side too much, and the filum terminale, which runs from the tip of the spinal cord, called the conus medullaris at L2, to the coccyx, keeps it from bobbing up and down vertically. Okay. Spinal cord's about the width of your little finger. Okay. Note that an infant spinal cord runs the full length of the spinal cavity, but as they grow, the vertebral column grows faster than the cord, and so below L2 is a cluster of nerves called the cauda equina that serve structures in the pelvic region and in the lower limbs. Okay, cauda equina just means horse's tail because it looks like a horse's tail. Okay, um, this is one of the reasons why when we do um, spinal tap, we always try to take um, fluid from below L2. The same is true when we do an epidural. We always do it below L2 so that we don't run the risk of damaging the spinal cord. Okay, because remember, the neurons in the central nervous system do not regenerate. Okay, you can see here an example of how a lumbar puncture is done. We have to go through the um, the ligaments that attach to the spinous processes, and then we have to go into the subarachnoid space and withdraw this material. We do this in the event that we suspect an infection. Okay, the patient is spread as pictured here so that the needle can be inserted more easily. Um, Remember again that the spinal cord, since it ends at L2, punctures from L3 and below don't present a danger. Now, unfortunate that you have to be awake during this procedure, okay? And it is painful, right? So, in the event that a spinal tap is recommended, um, just be prepared for the fact that this will not be a pleasant experience. Okay? Usually, when we're doing a spinal tap, it's also an indication of something serious that could damage the central nervous system permanently. The spinal cord is composed of white and gray matter. The white matter is on the periphery, and the gray matter is in the core. And in the middle of the gray matter is an opening called the central canal. The gray matter is shaped like a butterfly. The wings of the butterfly have a dorsal horn, which projects towards the back, a ventral horn, which projects towards the front, and in the thoracic and lumbar spine, a lateral horn that projects to the side. Okay. Remember that the gray matter is for signal processing and is made up of interneurons, non-myelinated axons, dendrites, and somas. Okay. The central canal is filled with cerebrospinal fluid and lined with ependymal cells and is a continuation of the fourth ventricle. Okay. And the white matter that surrounds the spinal cord is basically the signal transmission. And you could think of the white matter like a series of elevators that only go in one direction and only carry certain kinds of passengers. The ascending tracts only go up from the spinal cord to the brain and brainstem, and the descending tracts go in the opposite direction. So the descending tracts are motor information, and the ascending tracts are sensory information. And depending on which tracts we're talking about, We could be relaying information about body position or pain or um, visceral sensation. It all depends on which ascending tract we're referring to. Descending tracts um, might be sending motor commands to the upper limbs or the lower limbs. They might be carrying autonomic commands to the the thoracic and the abdominal pelvic viscera. Okay, um, and then the pathways for those are going to be unique for those commands. Okay, remember that um, when we're talking about commands that are coming down from the brain and brainstem, the connection between those command centers and the peripheral nerves are called the upper motor neurons. Okay, so they are the hookups between either the hypothalamus and brainstem and the peripheral nerves, or the cerebral cortex and the peripheral nerves. Okay, the ascending tracts are usually a series of um, on average 3 neurons that run from the um, the incoming information that hits the dorsal horn all the way to locations such as the cerebellum or the cerebral cortex. Okay, depending again on the nature of the information. So you can see the spinal cord here, the white matter. Those are the ventral, and those are the dorsal horns. Lateral horn, if it were present, would be right about here. And remember, that's only going to be in the thoracic and lumbar spine. Okay? And then you've got columns, right? You've got dorsal columns, which are going to carry primarily ascending information. The corticospinal tract is a descending tract, and the spinothalamic tract is an ascending tract. Okay, so it's a little bit of an oversimplification, but generally speaking, the ascending tracts are going to be on the lateral and the posterior side of the spinal cord, and the descending tracts are going to be on the anterior and lateral side of the spinal cord, but there are some exceptions to that. And invariably, with the exception of tracts that are up near the brainstem and the upper limbs, these pathways will decussate or cross, usually at the level of the medulla oblongata, or in some cases at the level of the spinal cord, before they go all the way up to the brain or the brainstem. And the same is true of commands that are coming down, right? Commands that come down from the brain or the brainstem cross at the level of the medulla oblongata, frequently in a region called the pyramids, which are the two little baseball bat-shaped structures on the front of the medulla. And the reasons for that are not entirely clear. Okay? Some examples of some important tracts. Ascending tracts are sensory tracts. The spinothalamic tract runs from the spinal cord to the thalamus, and it is a pain pathway. The dorsal column is going to run from the spinal cord ultimately to the cerebral cortex. Okay, and the spinocerebellar tract is going to run from the spinal cord to the cerebellum. So notice that these tracts are named for where they start and where they stop. Descending tracts include the pyramidal tracts, which cross at the pyramids of the medulla, and the extrapyramidal tracts, which are going to primarily deal with structures in the arms and in the head and the neck. Okay. Remember that decussation is something that occurs both in sensory and in motor pathways frequently. Okay, so the right half of the brain controls the left half of the body, and vice versa. Okay. Another name for the pyramidal tracts are corticospinal tracts. So They run from the cerebral cortex to the spinal cord. Okay. Um, Ascending tracts carry information such as temperature, pressure, pain, and touch. Motor tracts are going to carry commands for muscles, and autonomic tracts are going to carry commands for everything but skeletal muscle. Okay? The neurons of the central nervous system do not regenerate. Okay, so um, in the event that you have a break, the, uh, the wound will not heal. The immune system will move in and destroy neurons and lay down scar tissue, and that makes it impossible for the injury to repair via regeneration. Paraplegics have a break um, below the, um, the brachial plexus. Okay, so in the thoracic spine. All right, and the result is that they cannot move their legs. Whereas, well, I should say below the brachial plexus, anywhere below the brachial plexus. A quadriplegic is going to have a break in the cervical spine, generally below C4, okay, and they will have lost the use of both their upper and their lower limbs, okay, and the outcome of that is muscle atrophy and usually confinement to a wheelchair. Okay? If a break occurs above cervical 3, we call that a broken neck, and that means you die. Okay? The spinal cord is set up so that sensory information comes in through afferent neurons past the dorsal root ganglia to the dorsal root, and then synapses on interneurons that are in the dorsal horn, and then that information will ascend up to the brain or the brain stem, and then be integrated with other sensory information, and then the command center will send a command back down in the other direction. Okay, motor information comes out of the ventral root. The nerve cell bodies for the somatic motor neurons that talk to skeletal muscle are found in the ventral horn, and the neurons that talk to other targets than skeletal muscle are found in the lateral horn. Okay, both of these exit through the ventral root, and then they go to their respective targets. And so, when this happens, nerve fibers that could be autonomic and somatic and afferent and efferent can be combined in these nerve nets called plexuses in any combination. Most nerves in the body are mixed nerves, meaning that they carry both afferent and efferent information, and frequently you'll see mixtures of somatic and autonomic information in a single nerve. And the reason that these electrical leads don't interfere with each other is because of the protection provided by the endoneurium, as well as the myelin sheath, if it is present. Okay. All right. If we look here and observe what the spinal cord does, there are sensory pathways which are ascending, motor pathways which are descending, and then there are reflex centers which essentially don't involve the brain. And so generally with a reflex, what you have is a receptor, an afferent neuron, an integrating center, which is frequently in the spinal cord or the brain stem, an efferent neuron, and then an effector, which is the target that carries out the task. Okay? The spinal cord provides pathways for motor information coming from the brain and going to the peripheral nerves. The spinal cord also is a major reflex center and processes reflex information without the use of the brain. Examples include the coordination and the movement of arms and legs when you walk. Okay? A reflex is an involuntary stereotyped response to a stimulus designed to keep us alive. These were probably some of the most primitive pathways to evolve, and they don't involve the brain. So they execute more rapidly because there are fewer synapses in those nerve pathways. The synapse is the slowest part of any reflex arc, and so the fewer synapses you have, the quicker the reflex arc will execute. Okay? An example is shown here, right? A receptor, in this case, the Golgi tendon organ in the patellar tendon is stimulated. Sensory information is carried to the spinal cord. The integrating center takes that information and then sends information through an efferent neuron to muscle targets. The motor information from the spinal cord hits those muscles, which include the quads and the hammies, and the effector organ does the work. In this case, you kick. Okay, and the reason you kick is to relieve the tension on the patellar tendon so that it does not tear. Okay. Some other examples of reflexes include the withdrawal reflex and visceral reflexes. Examples, the knee-jerk reflex we saw in the previous slide is designed to keep the tendon or the ligament from tearing, okay, or to keep the muscle from tearing. The baroreceptor reflex is an example of an adjustment for maintaining blood pressure. And then the Babinski reflex can be used as a diagnostic to determine whether or not nerve function has been compromised, particularly in the upper motor neurons. Babinski reflex is basically the flexing or the extension of the toes. Okay. Normally, what happens when you do the Babinski reflex is you drag the handle part of a reflex hammer across the naked sole of the foot, going from the heel to the ball of the foot, sort of forming a little C there. And normally what will happen when you do that is that the toes will flex, meaning that you'll make knuckles with your toes. In the Babinski reflex, what happens is that the toes extend, okay? And that's seen in infants because their central nervous system isn't fully developed yet, but it's also seen in stroke victims and indicates upper motor neuron damage. So let's take a look at the components of a reflex arc.
Any simple spinal reflex involves an afferent or sensory and efferent or motor component. The reflex is initiated at a sensory receptor. These receptors are located throughout the body. The one shown here is in the skin. Stimulation of a sensory receptor results in the transmission of an afferent impulse along the axon of a sensory neuron. These axons end in the spinal cord. In most cases, the impulse will then travel through an interneuron within the spinal cord to synapse with a motor neuron. The resulting efferent impulse travels along the axon of the motor neuron to reach the effector organ. In this case, the effector organ is skeletal muscle, and the response to the stimulus is muscle contraction. As shown, the reflex functions to rapidly withdraw a body part from a harmful stimulus. The response takes place before the brain is consciously aware of the stimulus.
An important point regarding nervous tissue is that in the central nervous system, we talked about tracts, which are essentially bundles of white matter, myelinate axons that carry information from one location to another. And we talked about nuclei, which are areas of gray matter where signal processing takes place. In the peripheral nervous system, we have nerves, which are basically bundles of axons. Um, they have connective tissue in the form of fascia and their own blood supply. The connective tissue that surrounds each individual nerve fiber is called endoneurium. The fascicles of nerve fibers are surrounded by perineurium. And the entire nerve is surrounded by epineurium. And that allows the nerve to have access to oxygen and nutrients, but it also latches the fibers together so they don't twist, buckle, or kink, and it insulates them so that the electrical information going through these fibers does not interfere or short circuit. Okay. Note that in the peripheral nervous system, there's the potential for axons to regrow if the nerve fiber ends are flush. Okay, whereas in the central nervous system, that rarely ever happens. Okay. The two classification systems for the peripheral nervous system are the cranial and the spinal nerves. The cranial nerves made up of 12 pair, and some of them are sensory, some of them are motor, some of them are mixed. Okay, whereas in the 31 spinal nerves beneath them, all of them are mixed nerves. Okay, so when we look at the 12 cranial nerves, they're numbered from 1 through 12, 1 being closest to the nose and 12 being closest to the spinal cord. Okay, they each have different roles, right? And we're going to go through what each of the cranial nerves perform or do. So take a listen.
You're raring and ready to study actual nerve clusters found in all these different divisions of the peripheral nervous system.
An important cluster of nerves in the peripheral nervous system are the 12 cranial nerves and the 31 spinal nerves. Cranial nerves arise from the brain.
There are 12 pairs of cranial nerves, and with the exception of the vagus nerve, they all serve the head and neck area. These nerves are numbered in order from their location in the anterior of the brain to the posterior of the brain. In other words, from top to bottom. They can be separated into 3 groups: the sensory nerves, the motor nerves, and mixed pairs, which are groups of sensory and motor nerves. The sensory nerves are labeled 1, 2, and 8. The motor nerves are 4, 6, 11, and 12, and the mixed pairs, sensory and motor, are 3, 5, 7, 9, and 10.
Welcome to Cranial Nerve Countdown, where we give you the cranial nerves in descending order. So, in descending order, here we go. At the top of the charts is cranial nerve number 1, the olfactory nerve. This sensory nerve is responsible for smell. Next up is cranial nerve number 2, the optic nerve. This is the sensory nerve that makes vision possible. Making its debut at number 3 is cranial nerve number 3, the ocular motor nerve. Then at number 4, the trochlear motor nerve. Both of these nerves are responsible for movement of the eyes. 2 weeks at number 5 is cranial nerve number 5, the trigeminal nerve. It's the largest cranial nerve and is responsible for sensation in the face and the muscles that help us chew. The abducens is cranial nerve number 6. This motor nerve is responsible for right to left and left to right eye movement. Nerve number 7, the facial nerve, is dedicated to Bobby and Juanita. The facial nerve is responsible for facial expressions and the secretion of saliva and tears. So don't cry, Juanita. Bobby loves you. This nerve is grouped with the mixed pairs. Next on the charts is cranial nerve number 8, the vestibulocochlear. This sensory nerve is in charge of equilibrium or balance and hearing. The glossopharyngeal nerve is number 9. It's responsible for swallowing and taste. The vagus nerve, number 10, is responsible for slot machine regulation. No, just kidding. The vagus nerve is actually involved in the regulation of heart rate, respiration, and and digestion. It's even responsible for the muscles in the voice box. The vagus nerve is the only cranial nerve to pass beyond the head and neck and into the thoracic and abdominal cavities. That's quite a nerve. Cranial nerve number 11 is the accessory nerve. This motor nerve is responsible for head and neck movement and has won 4 Grammys this year alone. The hypoglossal nerve is cranial nerve number 12. It's found hiding underneath the tongue and helps us speak and swallow. And that's it for Cranial Nerve Countdown. Until next time, keep your nerves on the ground and keep reaching for the rewind button.
Another area of the nervous system that's jam-packed with nerves is the spinal cord. There are 31 pairs of nerves in the spinal cord that serve the body below the head and the neck. All spinal nerves are identified by the place they originate from along the spinal cord.
Altogether, the spinal nerves consist of 8 cervical nerves, 12 thoracic nerves, 5 lumbar nerves, 5 sacral nerves, and 1 coccygeal nerve.
And that brings us to the end of our little nervous system tete-a-tete. I hope you remember everything about the central and peripheral nervous systems, as well as their respective subdivisions. And if you find all this information to be a little hazy, just rewind.
The 31 pairs of spinal nerves are going to radiate laterally from the intervertebral foramina. There are a total of 8 cervical spinal nerves, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. And then below that, of course, the nerve cluster that we described earlier as the cauda equina. Each pair of spinal nerves is numbered according to the level of the spinal cord from which it comes. Remember that in the cervical division, the first cervical spinal nerve is going to emerge between the occipital bone and the first cervical vertebrae. Okay, the second one will be below C1 and so on, and then beginning with the thoracics are named for the vertebrae above them. Okay. The spinal nerves are going to branch and anastomose extensively after they emerge from the intervertebral foramina. Okay. Branching is where one nerve splits into 2 or more, and anastomosing is where 2 or more nerves merge into fewer nerves. Okay, so what will happen is that fibers will, in those nerves, split and anastomose, and ultimately will form nerve leads that serve structures in the anterior portion of the body, and those are essentially coming off of what we call ventral rami, and then in the posterior region of the body we have dorsal rami. Okay, the nerve clusters, which are called plexuses, are in the cervical, the brachial, the lumbar, and the sacral region. Okay, and the nerves that come off of them are going to serve structures basically at those levels. Okay, the cervical plexus runs from C1 through 4, the brachial plexus from C5 through T1, and the lumbosacral from T12 all the way to S4. Now, generally what we do with lumbosacral is we split it into lumbar and sacral. Lumbar would be T12 to L5, and sacral would be S1 through 4. Okay. Note that fibers from the cervical plexus supply muscles and skin of the neck. Motor fibers here also pass to the diaphragm in the form of the phrenic nerve, which allows us to breathe. Okay. Brachial plexus supplies muscles and skin of the shoulder, the arm, the forearm, the wrist, and the hand. Well, the axillary nerve travels to the shoulder and the arm. And the lumbosacral plexus produces nerves that supply the muscles and skin of the lower abdominal wall, the external genitalia, the buttocks, and lower extremities. Note that the sciatic nerve supplies muscles of the leg and the foot, as well as in the thigh. Okay. Now, there are some tables in your text that talk about the methods that we use to test cranial nerve function. 11.4 for cranial nerve function, and table 11.5 shows you the spinal nerve plexuses, and 11.6 describes the peripheral nerves that come from these plexuses that are important. Okay, so we can look at some of these important nerves. Cervical plexus, the phrenic nerve, is critical because it supplies the diaphragm, which is the main muscle of breathing. Way to remember, the nerve roots that supply the diaphragm, C3, 4, 5, keep the diaphragm alive. Okay. From the brachial plexus, the mnemonic is "my aunt rammed my uncle," and that stands for musculocutaneous, axillary, radial, ulnar, and median nerves. Okay. Sometimes, if you use crutches improperly, you can damage the axillary nerve, which serves structures in the shoulder, such as the deltoid and the teres minor. Okay. While damage to the radial, ulnar, and median nerves can impede the function of the wrist. Okay. So there are naming conventions. The nerves are generally named for the bones that they run next to or the targets that they supply. Okay. So, for instance, the axillary nerve is going to be near the armpit. The radial nerve runs next to the radius. The ulnar nerve next to the ulna, and the median nerve runs in between the two. Okay. The femoral nerve runs through the thigh. The obturator nerve passes through the obturator foramen of the coxal bone. The sciatic nerve passes through the sciatic notch and is the thickest and longest nerve in the body. And the tibial nerve runs next to the tibia, and the peroneal nerve runs next to the fibula. Okay, so those are some conventions that help you locate these different nerves. You can see an example of what happens when we develop something called a repetitive motion injury. Okay, a repetitive motion injury comes from performing a relatively minor task many times. An example is carpal tunnel syndrome, where the nerves, the median nerve, and the ligaments and the blood vessels that pass through the carpal tunnel, which is formed by the carpal bones in the wrist, becomes inflamed, and that causes numbness and tingling at the wrist and loss of motor control. Okay, and we usually treat that with a brace and with the use of an ergonomic keyboard so that you don't continue to exacerbate the damage. Okay, sciatica can be caused by a ruptured or herniated intervertebral disc. It's common in pregnant women because of pressure of the enlarging abdomen. It's also a problem in obese individuals, and it produces pain in the hips and the lower extremities and loss of motor control. Okay, one of the ways that we can deal with this, aside from losing the weight, is we can do laser spine surgery, right, in order to take some of the pressure off of that nerve and restore some function so it doesn't become damaged. This is one of the reasons why abnormal spinal curvatures, which we talked about in the skeletal chapter, can damage spinal nerves, and the result are that the targets lose motor control and you lose sensation. And those are called radiculopathies, and they're dealt with by osteopaths and chiropractors. The dermatome is just an area of skin that's innervated by a particular spinal nerve, and they're named for the nerves that serve them. They can be used to locate nerve damage. They're also used by surgeons to determine which spinal nerves to numb in anesthesia in order to prepare you for painless surgery. Okay, the diagnostic use for this is to test for sensation in particular dermatomes, and if you can't pick up any sensory input, then we can determine which spinal nerve is damaged. Okay, which can be the result usually of trauma. Okay, or some disease processes like osteoporosis. So remember that there are functional classifications as well. Somatic afferent nerves are going to bring body position information into the central nervous system, so that would be information from our joints and our muscles and the surface of our skin. Okay, while somatic efferent nerves are going to target skeletal muscle, and that's how we do voluntary movement. And the autonomic nervous system is going to target everything but skeletal muscle. It's an efferent division, and it's responsible for maintaining the body's homeostasis. Okay. All right. That brings us to the end of this podcast. Again, if you have any questions, I'll be happy to answer them by email. I should get back to you within a day. And I thank you for listening, and I will join everybody in the next podcast. Thank you very much.